There we go. These meetings go on to our PFAnetwork website. So we are recording for that. And live transcript is available if you would like to have it. There's an option at the bottom. It says CC live transcript. Just click on that and you will have the transcript available to you. Next slide. We do have these agreements coming into the for every meeting that we have. They are practice active and empathetic listening and sharing, challenge the idea and not the person, be both teachers and learners, take space and make space, stories stay and lessons leave, use I statements, one person speaks at a time, and be here now, be present with us. Go ahead to the next slide. All right, welcome. Since we have so many people here today, thank you all for being here. If you could put into the chat your name, where you're calling in from, and what's your favorite type of movie? Put that into the chat. All right, and go ahead to the next slide. Ooh, historical dramas. All right, I'll go ahead and pass it off to Libby to introduce Michelle.
Great. Thank you so much, Laura. And thanks to everybody for taking some time out of your Friday to spend a little time together supporting each other through this PFAnetwork community. We are really honored to have today Dr. Michelle Schreiber from CMS, and I will let you read her many credentials and accomplishments. And I would like to just provide a little bit more of a personal introduction. The first time that I met Dr. Schreiber was at an IHI conference where she was doing a really different session from what I had experienced with CMS staff before. She really was asking questions and listening for the answers and taking in everybody's input, whether there was clinicians in the rooms or nurses in the rooms or quality improvement staff and patients and families. Lindsay and I were in that same session and took in all of that insight and information within with equal weight. And I really appreciated the table that Dr. Schreiber set for us in that session. And I just want to say she has been consistent with that approach throughout all of our work to engage patients and families from the PFAnetwork into measurement activities, which has admittedly over the last couple of years been a really complex and difficult lift to try to figure out how do we do this in a really important and meaningful way. So I was on a session with Dr. Schreiber not too long ago, and the subject of healthcare staff burnout over the pandemic came up, and I mentioned to her, you know, I'd had a couple of conversations with our PFAnetwork members and heard the burnout from all of you as well, and thinking, man, I volunteer hours, I give a lot of time, I share my personal experiences with the hope that it will improve the health system, and I'm just not sure that it's happening. And that's a really, you know, we all feel that at one point or another. And so I shared that with Dr. Schreiber and invited her to share a few words with our community to just help us keep up the work, keep energized, keep engaged. I know it's hard, you guys, but we are making some real changes for people and for systems. And that system change takes a long time. But I really think if we stay in the partnership, we can continue to create great things. So Dr. Schreiber, I just want to invite you in and welcome you to the PFAnetwork. This is our family meeting, and really happy to have you with us today.
Oh, Libby, thank you very much. First, let me check. Can you hear me okay? Wonderful. My computer sometimes has issues with that. It is a pleasure to meet all of you virtually and to see what your favorite movies are, be it historical, documentaries, to comedies, to my favorite is an old ballet movie. but it's really a pleasure. And just by way of a little bit of background, so you can understand my really deep and passionate commitment to the patient advocacy part of safety and healthcare overall. I've been at CMS for really just a little over 3 years. So I've had a long career before CMS. I've been a chief quality officer, a chief medical officer, a leader for information technology and healthcare, largely in big systems. I've served, as you see here, in the state of Michigan on our statewide initiatives for quality and safety. And at each and every turn, have always been impressed how when patients are in the room, patients are telling their story, that it brings a sense of a dose of reality, quite honestly, as well as a perspective that is unique and unparalleled and absolutely vital in establishing a high quality safety fabric of any organization and of anything that we do. So I had been the chief quality officer of the Henry Ford Health System, actually, where we had a wonderful program that had been sponsored by PCORI to actually train patient advocates. And then once trained, we would kind of find them roles within the organization, such as sitting on the board of trustees or sitting on other committees or participating within divisions or groups. And it was just phenomenal. Again, every single time it changed the tenor of even a project a specialty group might be doing, or certainly sitting on the board of trustees. We made sure that we started our meetings with patient stories, and that too, that changes the tone of everything. And even at the National Quality Forum, where I sit on many committees, making sure that we have the patient voice there, I will tell you, has shifted conversations, sometimes from yes to no or no to yes. But that perspective is just, we can't have enough of it, actually, in my opinion, because who better to ask about their healthcare than the person getting the healthcare, really. I'm a big believer in having more patient voice, and we're working on opportunities for how do you make that happen. Ensuring, for example, that patients have access to their records, patients and caregivers, I must say, have access to their records, have open notes, have the ability to make corrections into some of those notes. That's something that actually the Office of the National Coordinator is working on right now. For patients and their loved ones to be able to report safety issues, making sure that we are moving our measures in a direction where we have many more patient-reported outcome measures. In other words, I really think that ensuring the voice of the patient in a very large and meaningful way is really what we need to make healthcare better. It's one of the fundamental steps to make healthcare better. And to that end, when we talk about resilience, let me just talk about what happened during the COVID pandemic. I mean, we all know, we've all been witness to it. Most all of us have been impacted in our families, or our friends' lives in one way, shape, or form. The stress has been enormous. The learning of the country has been enormous. The divergent opinions have been interesting, shall we say. And I think that's part of the learning. Other things that we have learned is we need to do a lot better with our data as a country to make sure that we actually understand what is going on. We need to do better in preparedness. We need to do better with our workforce, who really took a lot of the brunt of this, and make sure that we are prepared and resilient and flexible for the future. But just as this has affected the workforce, which I am sure you see and you feel, I can't imagine that it doesn't affect you as advocates as well. People are, frankly, they're tired, they're burned out, there's less and less staffing, the priorities are really all about how do I get through the day. And you may feel as if your voice doesn't count as much, but I'm here to tell you that your voice matters more now than ever before. We have to hear the voice of the people who are engaged in care. This affects you in a personal and direct way, and we need to ensure that we're hearing those voices. So whatever it is that you're doing, I would say, remember that you are vital. Your voices are vital to having a great healthcare system that is safe and has the highest outcomes and that serves every individual, and frankly, every individual with respect, dignity, and equity. And we can't do it without your voices. So hang in there, I guess, is the best I can say. Take solace from each other, even in meetings like this. You know, the ability to talk to each other, I think is great. Take solace from your families, and know that those organizations, those committees, those places where you're raising your voice, they need you. And that's really my message. I'm happy to answer questions, by the way, but that's really my message, is that your role is just vital and we need to do more of it.
All right, so.
Thank you so much, Dr. Schreiber. I really appreciate you taking.
By the way, call me
time.
Michelle. You
Oh.
and I have known each other long enough.
I know, but I was.
Do you have a number for the insurance company that you've talked
Yeah,
with?
you're on with the family now, so yes. Thank you, Michelle.
Oh, I said, do you have a number for the insurance?
Oh, Marty, you might want to mute. There we go. Thank you. So anyway, I just want to thank you so much. I don't know if anybody else has any gratitudes or questions related to the support for patient-family engagement that Michelle has just really nicely articulated. Any?
Hi, this is Connie Montgomery. Can you hear me?
Yes. Go ahead, Connie.
I'd like to say I just met Dr. Michelle recently in the orientation for the new CMS TEP panel, and which I'm a member of. And I tell you what, I'm just excited to see the work going forward, because they actually really want to hear the patient voice, and that's wonderful. Thank you.
Thanks, Connie, and thanks for your commitment. I think there's just so many new avenues to partnering with CMS. Sorry, Michelle.
This is Tim. Can I ask Michelle a question?
Sure.
Michelle, one of the things I keep wondering, I've been involved a little bit with PCORI also, because most PFAT are actually more involved in the quality improvement area. But in essence, quality improvement can be a pilot for CER type of research, but nobody really tried to relate those two, because quality improvement usually go through A3 and all the things, but in essence, it's very easy to translate the information in a way so it becomes a potential clinical research. Because in a sense, a lot of the care delivery area improvement that PCORI supports could involve far more the PFAC members. I'm wondering if you have any thought about that.
You know, I think your point is well taken. It's largely not CMS, but AHRQ in particular, the Agency for Healthcare Quality and Research and Quality, I got it backwards,
Right.
that would do that. And we have, you know, very good relationships with them. I'm happy to talk to them, but I also think that it is one of their fundamental commitments, as a matter of fact. And so connecting the research, we think is extremely important, because the research is what produces sort of the evidence that all of us need to be following. And really patients weighing into that are important. You know, even the research on new drugs, for example, you know, recall CMS's position on the new Alzheimer drug mandating clinical trials, because we're looking for experience and we're looking to hear in a way that is the voice of the patient. It's the outcomes. And so I know we're deeply committed to having patients on all of our technical expert panels, having patients really involved in, you know, the National Quality Forum consensus-based committees. And I know that AHRQ is committed to having patients in research as well. And I will be sure and mention this to them as well. That's where most of it would occur.
Thank you.
Mhm. And I saw Nancy Brockerman had a hand up. Go ahead, Nancy. Nancy, you're on mute if you're speaking. All right. Well, you're welcome to put your question in the chat as well, Nancy.
I think
But
I'm there.
There she is.
Oh, there we go.
This time it gave me a thing to click on. I was in the Henry Ford system from my 30s until I left Michigan at 60, and I'm in New Mexico now. At one time, I was an employee of the system when I was a receptionist for the psych hospital north of Detroit. So hearing somebody on my home grounds, even though she's moved on to different things, is like enlightening for me to see. Thank you.
I'm still based in Michigan, actually. I commute to Baltimore, Washington. Now with the pandemic, most of us have actually been working at home. So Henry Ford is still one of my very favorite places. And I'm glad you were there.
Funny how we get so attached to our home bases, right?
Yeah, well, it helps that my husband is here, you know.
Well, there's that.
And a minor point, you know.
Right, right. All right. Well, I know that you are such a busy person. And so for you to take time out to join us this morning or this afternoon, I really appreciate your time. I know the community appreciates hearing from you, and we'll share this recording again with the larger community as well. So you are welcome to hang out and listen to Naomi and her colleagues thinking about the benefits cliff and how we appropriately compensate patient family partners, you know, without causing any damage there. So that's our topic for today. But
thank you. And I have, it's a pleasure. It's really a pleasure speaking to all of you. I do mean it sincerely. Your voices are so important. But you're right, I do have to head to another meeting. But thanks for the opportunity, Libby.
Anytime you want to reconnect with your why as to why you're doing all that hard work in Baltimore for the people that are experiencing care, you know where to find us.
I will. Thank you so much. Have a good morning or afternoon, whatever time zone you happen to be in.
You too, Michelle. All right, Laura, I'm going to turn it back to you.
Sure. And I'm actually going to turn it over to Naomi. If you want to go to the next slide, Lindsay. Thank you.
That was quick.
Yeah.
Great, thank you. Good afternoon or good morning, depending on where you are coming from. I am Naomi Williams. Thank you, PFCC partners, Libby and team, and for you all, the PFA network. I'm excited to be a part of today's coffee chat. I am not going to read my bio. Just know that I come to you from a little town in Georgia. It's not so little, but we host a little golf tournament called the Masters. So I'm coming to you from Evans, Georgia. I am the proud mom of an almost teenager who keeps me on my toes and is the reason why I have been inundated, if you will, in this work. I am a proud consumer scholar with the National Center for Complex Health and Social Needs. When I found them, that was almost like a lifeline, such as PFCC partners, and being able to find my people, if you will. And so that's a little bit about me. If you go to the next slide. And being a national scholar, one of my cohort colleagues is Emily Alemeada Lopez. She may be joining us during this session. You know, life happens. So if she pops in, great. And if not, just know that Emily is a part of our team as well. And Emily is a transgender Filipina American with cerebral palsy, and she specializes in disability and LGBTQ plus policy issues. If you go, well, no, don't go to the next one yet. Sorry. I also wanted to mention our other colleague for this particular project is Katie Bahrain. And so the three of us, in addition to Shelby, if you'll go to the next slide now, thank you. And the three of us, in addition to Shelby and Evelyn, we comprise the public policy piece of the cohort. So I am going to turn it over to Shelby so she can introduce herself and tell you a little bit more about the National Center as well as the Consumer Scholars Program.
Hi, everybody. Good morning or good afternoon, depending on where you're located. Like Naomi said, I'm Shelby. I am the Policy and Advocacy Manager at the Camden Coalition of Healthcare Providers. And I'm working closely with Naomi and our other team of National Consumer Scholars on this policy-related project. So I guess I'll give you all some background on us, on the Camden Coalition, and on the National Consumer Scholars Program. I'm not sure, Naomi, I know we have our slides. I'm not sure if they're part of this deck or if I should bring those up. Oh, perfect.
They're a part. Yep.
Oh, wonderful. Yes, we can go ahead and go to the next slide. Like I said, the Camden Coalition is a multidisciplinary nonprofit working to improve care for people with complex health and social needs in the city of Camden, New Jersey, as well as across the country. And we do that through that national level work through our National Center for Complex Health and Social Needs. And the National Consumer Scholars is a program of the National Center that really works to bring together individuals with lived experience in order to do a range of exciting, interesting work, including taking part in leadership development and peer-to-peer learning activities. They play an active role in our annual Putting Care at the Center conference, which is taking place this September, as well as working with National Center and Camden Coalition staff to develop and inform the field of complex care. So in terms of that last bullet, part of this work is each consumer scholar works on a project team. And one of those teams is our policy team that works closely with me and my other colleague, Evelyn, who was unable to be on the call today. So this year's Consumer Scholars Policy Team is working on a project focused on the topic of compensation for consumer advisors, and really on just like the impact of that sort of compensation on public benefits recipients, and really also thinking more broadly about the way that, benefits cliffs and limits on income and assets really affect folks that receive public benefits. So I'll go ahead and hand it back to Naomi to talk a little bit more about the project and specifics.
Thank you, Shelby. So in your own words, we have here the question, what is the benefits cliff? So before giving you that technical definition, would anybody like to share what that means to them? I know this is not a shy group.
I can guess.
Okay.
I would say there's a point at which if you earn $5 more, you will be without the support of the benefits that you had until you got up to that benefit. And then it's like falling off a cliff because you're in a bit of never, never land that you don't experience.
There are
That's
also
just a guess.
There are also multiple health insurance policies which have a lifetime benefit. And if you have catastrophic illnesses or injuries, you can hit that lifetime benefit pretty quickly and fall off that cliff.
Thank you both. Nancy, that is where, and Laura, if you'll click on next or whoever's going. Yes, and Sherry, that I had not thought about the lifetime max, which is very true. I see it on our statements, but hadn't thought about it in that way. So that is so true as well. So thinking of what we were looking at for the purposes of this project, the benefits cliff, is looking at where people face, or what they also call the cliff effect, when they receive public benefits from the government, earn or receive additional income, and then you discover you make too much money, but you're not actually making enough money to sustain your household. So Nancy, just as you said, you go over $1 or $5 more than that cap, and then your benefits get reduced and or cut off. If you go to the next slide. So with our public policy project, we had a lot of discussion because there are so many different areas in looking at how you can potentially fall off of this cliff. So looking at it from, and the reason that we're coming to this group is knowing that how your voice is heard, how your lived experiences are connected with various projects, and how a lot of times with that, there's the opportunity for compensation. So one of the things we're looking at, so the problem statement says, and I'll just read it here. It says, it is vital for healthcare and social service organizations to partner with consumers or people with lived experience to inform the design and operation of their programs, especially individuals from historically underrepresented communities. And paying people fairly for their work is an essential practice to building equity and inclusion. Too often, outdated public benefits eligibility rules and income limits prevent consumer advisors and advocates from accepting payment for their essential work without risking losing their life-sustaining benefits. So, in a nutshell, basically saying our voices are needed to help craft programs and or enact change to represent all people, if you will. And then there's compensation. We should be compensated for our time, but then the laws around service benefits have not kept up with those payments. Or that, Shelby, help me. I feel like I'm falling.
No, I think you're doing a great job. Yeah, I mean, I think that the way that, when we think about ethically compensating consumers and family advisors like for their work, that the way that the public benefit system has not kept up with the way that world has evolved and the ways that organizations are starting to learn about the importance of compensating folks that they engage in their community engagement efforts. And so really those two things are coming up against each other. And we're trying to figure out, or, trying to think about ways to advocate for changes to how the public benefit system is run in that way, to sort of be able to make those things ultimately and allow people to be, paid for their time and expertise and actually, and work, and to have this work acknowledged as such, without people losing their essential benefits that they rely on oftentimes to stay healthy and to provide for their families.
Thank you. So an example, I work well with examples. So let me work to give an example. In speaking with someone earlier, they receive Social Security. So they receive a check, say, for $500 a month. And then any income that is earned outside of that, they have to report. So let's say it's me, I'm making $500, I receive $500 a month from Social Security, and I get connected with an organization through the network. So I work with CMS on a project, and they have a stipend where the stipend is, say, $1,200 for me to work with them for 12 months. Well, when I report that, that's going to put me over the income threshold, and my benefits that I'm receiving from Social Security are going to be reduced, if not lost altogether. So then I have a decision to make. Do I participate in this project with CMS and influence that project from a lived experience perspective, and risk losing my benefits? Or do I say, no, I can't participate because I'll lose my benefits, or I'll participate, but you can't pay me? So we have these options, and none are good options. I see a hand up. Yes, ma'am.
I experienced this myself when I was on Social Security disability. And I was asked to be the clinical coordinator for a phase 1 clinical trial. And the compensation at that point, as an independent contractor, as a self-employed person with expenses, I could not make over $800 a month in addition to my Social Security without losing the Social Security. So we did some creative financing. We took the employer that was hiring me, put the monies that were allotted for my salary into a bank account. And then he would use that bank account to pay my transportation. He would use that bank account to pay for continuing ed or conference costs for me. And it benefited him as a staff development write-off. So I got the benefit of it without having to report it as income. And I think sometimes if we're engaging an individual for the benefit of their voice, just that conversation of what are your needs, what are your interests, is there a conference you'd like to go to that we can cover the cost of the conference and maybe even lodging for you from the amount that's allotted for you. I think those things can really help the individual to feel like they're contributing without their contribution being a burden.
Thank you for that. I just saw in the chat that is a very interesting and creative way of working with not pushing somebody over the cliff. So thank you for that. So part of our main reason for coming today is to see, have any of you, or has that happened to you? So thank you. Is it Sherry or Cherie? I think I ask every time I see you.
It's Sherry.
Okay.
It's spelled Cherie, but it's pronounced Sherry.
I like to ask. I don't like when people mess my name up, so I try really hard not to mess others. So to see if you, or if you know someone who has been impacted by the benefits cliff, or in this situation, we are working to collect stories. And so even if you have a story you don't feel comfortable sharing out in the open here with everybody today, we invite you, excuse me, to share with us on the back end, and we can make it anonymous. But we do want to hear how this has impacted, or if others have been jeopardized, and how do we make this work? So our end, and Shelby help me here, but our end goal is to have a document, and more so videos that live on the website, where people are able to say, this is my lived experience, this is what I have to bring, but this benefits cliff is jeopardizing. So how do we continue to make it equitable and inclusive with the barriers?
Yeah,
I said
definitely.
that okay?
Oh, no, I was just going to say, like, our end goal is twofold. As we're putting together this document, it's sort of a policy brief with recommendations on how this could be improved on more of like a systems policy level, but also the videos that Naomi's talking about, sort of really to raise awareness and to give a human face to this issue, and to help decision makers, but also the general public, other people in this field, understand the impact of this issue and how it affects people's lives, and what that actually looks like. And to, like Naomi was saying, like, a lot of us really learn and take in information best with like stories and real people and examples like that. So like that's the point of the videos, and we'd be super excited if anyone here, if others that have dealt with similar issues, were willing to either participate in a video or even share a written anonymized version of your story that we can include.
I see Nancy's hand. Is that Nancy?
Yeah,
No.
Nancy B.
Nancy B.
Stu.
I saw we have two Nancys on the call. The situation that Sherry described was creative, wonderful. It was absolutely a win-win situation. The barrier to that in many situations is going to be those people that, those mischievous individuals that want to fake something to get benefits. And then what kind of vigilance system is there going to be to spot those? Unfortunately, in the state where I live, there was a person who was a full-time employee of a major school system who was also a legislator for our part-time legislator. And she had a little private company that seemed to get 100% of some of the contracts. She's no longer in office. She's either in jail or going to be there. But there's going to be resistance by those folks who are, maybe they've been burned by fraud themselves. So I think Sherry's solution was wonderful if somebody else is actually dispensing the money and they both know where it's going. But that is a topic that you'd want to have handled to avoid a problem.
Yeah, it's a really good point, Nancy. And certainly there are those out there with nefarious motives. But I think in the context of patient-family partners and people with lived experience partnering in the health system, I haven't experienced that. It's not to say it hasn't happened, but I haven't experienced that. I think people like you and like me and like everybody else on the call are really interested in sharing their experience navigating the health system so that we can improve it together. And I really appreciate this conversation. And one question I have for Shelby and Naomi, this was a really new concept to me until it's funny because, your brain dissects things. And so I always thought this was a problem in the disability community. And it wasn't until more recently when we started really looking at compensation practices within the PFA network and with PFCC partners that we came to realize, no, this is actually, an issue for a lot of patient-family partners as well. But I'm not sure patient-family partners are always aware to think of it in that way, much the same as I wasn't. So are you finding there's an awareness need as well with patient-family partners themselves to recognize they may be putting themselves in jeopardy that way? Or was that just me really slow catching up on the curve?
Yeah, Naomi, I'm interested to see what you've been hearing. I think from my perspective, I had a lot more exposure to it as well, like in the disability community when someone, receives disability benefits, but also may want to work in some way or do some sort of have some sort of employment, but isn't able to do so. But Naomi, I'm interested to hear what you've been hearing.
It's I don't know if it comes out. I'm more familiar with it from supplemental security income because my child is a minor, so my income would impact his benefits. I do have friends who are adults and they are in a they're fixed income, so it's I can't make more than $2,000 a month or my benefits will be decreased. And so I don't know if it's ever really we look at it in the sense of I can only work so much and then this will happen. I think the other thing, more of what I've seen is when doing more kind of one-offs where you work with a group for one time or a short project, not realizing that you have to account for or report that income. And so that's kind of what I've seen, and that touches on what Ting put in the chat in the sense of can it be classified as reimbursement versus 1099. So when you're talking about 1099, people get 1099 when it's 600 or more within a year, right? But when you talk about from even with reimbursement, if you're receiving funds, so even if you work on a project and it's $300, technically I'm supposed to report that because that's earned income.
Whereas the suggestion to pay for conferences or transportation or things like that, would not be.
Right.
Where there are. But obviously, but the problem with that is that doesn't help people put food on their table and manage their expenses, which is.
Yes, that's that's the that's the dilemma, I guess, right? So just as Dr. Schreiber just said, you know, our voices are needed. We need to be at the table. Don't stop, don't give up. But with that, so how do we bring this issue to light and then move the needle to where it is equitable and inclusive?
Now, when an employer or a company sends somebody like an Amazon gift card as compensation, does that count as 1099 income for the individual receiving it?
It has to be declared.
I'm not sure. I know that there are a couple of like legal questions that I'm not as familiar with, and I wouldn't feel comfortable answering for sure one way or the other. So if there's someone with more expertise on the call, I welcome them to offer answers. But I know at the Camden Coalition, we have done some creative reimbursement, Sherry, like you brought it up and you experienced in terms of offering gift cards, but also paying people with stipends over a longer period of time rather than, you know, hourly. So there are some creative ways we've been able to address it in, you know, alongside our legal counsel, figuring out what makes sense and what not, really wanting to make sure that people we work with like aren't put at any sort of risk by but we're still able to pay them or compensate them in an equitable way. But yeah, there are definitely a few questions. And actually the Camden Coalition, we put together a short brief last year that was more generally on this topic that I can actually share in the chat right now that has that our folks on our legal team actually worked on.
I would love to see that.
I think,
go ahead, Sherry.
I think part of the biggest problem here is that Social Security has not kept up with inflation. Families are having trouble putting food on the table, and they're being penalized if they do a little extra something. It's got to be done under the table, and that puts the burden of not being truthful on the individual.
So I don't know if this is Linda Starnes, and I put in the chat about the current conversation in DC that is going on a bipartisan effort for a bill to come forward to change the now 30 years status of holding assets at $2,000 for single people and $3,000 for married couples who receive benefits. So it is so goofy that it has taken this long for it to reach the legislative level that it has reached so far. But we've got a lot of our national disability organizations who are staunchly behind this and putting out information for folks to be able to call their senators with an informed comment or send an email that speaks to this need. And that's another place where stories are heard, is if you have that within your advocacy to your legislature. So I would just suggest that look into that and see where your heart leads on that. But the bill is actually also has in the wording as it is now, the consideration of it not going stagnant again like it has, but as cost of living raises, those cost of living increases will occur within this this particular statute. So anyway, I'm so hopeful because I have a son who is affected by this as well. And it's going to rule his life likely for all of his life. And we are very hopeful.
I'm so glad you shared that, Linda.
Yeah, it is so past the point of need. And I will also say, if you all are not familiar, for people with disabilities, and there's some caveats to it, but there's something called the ABLE account that every state has available for those who qualify to be able to put money in a savings account beyond these limits. And it's non-taxable. And it has been such a saving grace for when his grandmother would want to give him a gift, of a financial gift, and it would harm his bank balance status, but it can now go in an ABLE account and it doesn't harm that status for him. So the ABLE account is a wonderful provision as well.
Linda, can you say more about that? How is it something that he can access regularly?
Yep.
Okay.
And I think that this came into being maybe, I'm going to say 5 or so years ago, and it's state run. It's a federal. There's federal regulations, but states established their own state level ABLE bank account for clients who are meet the qualifications to be able to set up an account. But he's got a savings and checkings account through his ABLE account, as well as he just has his regular old Bank of America account, and that he can then move as he receives money that he puts into his regular bank account. He can then move it over to his ABLE account, where again, he will be able to save over the years up to $100,000 without penalization.
Wow.
So it was such a needed piece for people to be able to save money and have money for catastrophic events that occur to any of us. But if you can't save enough money to cover for a catastrophic event, you're left helpless. So that's every state. I'm pretty certain every state in the country now has one established for people with disabilities.
And they made, well, part of that, the state, thank you so much for that, Linda. Part of that came about where families that could save for their kids going off to college, and for families that had children that would not be going off to college could not save. So it made a way to prepare and plan to have financial stability. I know I saw Nancy, and that may be something to come back to and have another coffee chat about that resource, because it does affect us. I saw Nancy B's hand, and seeing, I know you had mentioned something in the chat, so I want to come to that as well. So Nancy.
Thank you, Naomi. What occurs to me, particularly if somebody's working outside their base income for a project, if the regulations can be changed so that there would be a review, let's say 4 months later, that a computer program could implement. In other words, if the income is going to trigger a reduction in benefits, that you wouldn't have to wait 1.5 years to get reevaluated. You could level with the truth about it. And I mean, to a certain extent, when you get the extra benefits, you can take that money to the grocery store or the gasoline pump, but you shouldn't be deprived for a very long time just because the IRS maybe doesn't have enough employees. That's my brainstorm of the moment.
Thank you for that. That's what we're working to get at. And as Linda brought up, the fact that it's been 30 years since there's been an adjustment, it's just unfathomable of how people are making it. And so when we, again, if you have stories, if you'll go to the next slide for me, Laura, and we'll come back to this, but I know we're coming down towards time. I want to make sure if you are open to and willing to share your story, if you would contact Eveline, and her email address is up here. It's E as in egg, Kane, Kane, at camdenhealth.org. Or you can call her, and that number is 856-701-2793 as well. If you're open to sharing, if you would please get in touch with her. But we want to move the needle because we're able to work. We may not be able to work a 9 to 5 or something that would take you off of requiring or needing public assistance, and that's not, needing public assistance is not a bad thing, right? So getting through that stigma that in the stereotypes of those who utilize public benefits or public assistance, but why are people being penalized for working? And so, or having to make the decision between, do I give my voice, and how do, I'm asking a whole lot of things here, rhetorically, if you will. But looking at, when working with these programs, how do we help the organizations that we are working with include us and be equitable in what should be without harming us?
Naomi, that's such the big question. And I think that the way you guys are approaching it together and the way the Camden Coalition is bringing together is the only way that's going to get solved. It's not that the Camden Coalition or PFCC partners or Acumen or others that we work with don't want to provide those compensations. And that's a whole different conversation that has evolved over the last, 5 years, so that organizations are very comfortable and eager to provide that equitable compensation, but there's these restrictions. So I don't know. Connie,
Social Security has a trial back to work period for people that are on disability. And the way that works, in a 60-month period, a 5-year period, if during that period, the individual on Social Security disability earns more than $750 outside of expenses in a month, they have a total of 9 months during that 60-month period that they can earn that much over their Social Security without getting kicked off Social Security. But you have to be in a relationship with somebody in your local Social Security office. I was in that program for 3 years and did not, even though some months I made $1,400 or $1,500, that month stood on its own in that 60-month period. And I'd never had 9 months that were that much over. So it could be scary to hit that sort of cliff in 1 month, but if you really work the program as it's set up to help people get back to work, you do have a 9-month total period over 60 months where you have the ability to make over that amount, but you got to work with somebody in your local Social Security office.
Thank you. And Connie, we're going to come to you next, but thank you for bringing that up, Sherry. The point that stands out the most to me on that is that you have to know that you have to work with somebody. So you have to be involved in a program in order for that not to negatively impact you. So if you don't know about that program, how do you get in it? Connie?
I think you guys, can you hear me well? Are making some great points today and sharing some very needed information. On 10/20/21, my mother passed, and my brother, who's turned 23 now, is autistic. And then my sister, who is the oldest of us all, she's 58 now, and she had 2 strokes in May of 2020. So when Mom passed, that left me trying to find some of these answers you guys are talking about, like, okay, what Mom left for them, where do I place it? Because she was wise enough to set aside what funds she had, because she knew she had 2 adult children that would need extra care and extra help long after she was gone. So, but I ran into some of these situations of, okay, do I put it in a checking account, a savings account? How do I handle this? Do I just take the advice from the banker that spoke at my mother's funeral because they were so close, or do I get legal advice? I did both, and I'm thankful I did, but I definitely recommend us going and advocating at the national and federal level for those of us who have disabilities or have family members with disabilities, or both, for us being able to add our voice to these projects and to these organizations, so that we can help them see the bigger picture and the quality of life that is impacted on each individual who wants to need services from the government monthly that they get, but also who want to be a voice. That's just a barrier, and we need to remove it. And the only way that that can be done is by people with lived experiences. Thank you.
Thank you, Connie. Thank you.
You're
So
welcome.
again, if you all are open and willing to share your story regarding, or if you know someone, so it doesn't just have to be you, if you're willing to share with us or connect us with others. Again, this could be a super broad story gathering, so we're really working to look at and focus for those who are advisors or those who work in a patient expert role. So if you have had to turn down, or if you've had the choice, had to make the decision of whether to engage in a project and get compensated or not engaged at the fear of losing your benefits, please connect with us. Shelby, do you have anything else? I know we're running close on time.
I think that was a great way to end things. I really appreciate you all allowing us to come and present today. I'm really happy to meet you all.
Thank you. And thank you both, Naomi, Shelby, and all your other colleagues. You all are doing very, very important work out there. We will put this call for stories on the forums. And I think we will also do a call out in our newsletter that goes out next week. So when you see that, please share that info with the people you know that have stories to tell, and we will make that broad call and have all kinds of stories collected. So thank you all for joining us. And if you do have a topic like this that you want to share with the PFA network, please feel free to email me. I'll put my email in the chat, and we will get you all set up for or it's right there. We'll get you all set up for the future coffee chat. So thank you all for joining us.
Thank you.
Thanks, everybody. Great session.
Thank you.
Bye.
Bye.